Very good evening, sirs. We are live now.
Greetings to all. This is Chandramohan, musculoskeletal physiotherapist from India. Welcome you all back again for ExRxIndia's e-learning program after a long break. For today's program, we have participants from Sri Lanka, Nigeria, Egypt, Qatar, Pakistan, Philippines, USA, Rwanda, Malaysia, UAE, Sudan, Saudi Arabia, Kuwait, Bangladesh, UK, and of course, India. Thank you all for taking time to register for this World Physiotherapy special webinar series, which will be happening today and tomorrow. Today, we have Mr. Nelson Arputharaj John, lecturer, MAHSA University, Malaysia, to talk about osteoarthritis, a neurological condition. Mr. Nelson Arputharaj John, lecturer, has been in the field of physiotherapy for more than 20 years with both academic and clinical experience. He graduated from the Tamil Nadu Dr. MGR Medical University, Chennai, and did his postgraduate degree in 2007. He has been a passionate physiotherapist specializing in neurological rehabilitation, evident by his popularity with students and patients. He has conducted workshops in stroke rehabilitation using neurophysiological approaches and has attended various adult and pediatric neurological workshops and courses organized by internationally renowned persons in the field of physiotherapy like Dr. Mindy F. Levin, Canada, with special interest in motor control theories. He has treated various adult and pediatric neurological patients with various approaches like NDT, sensory integration, and MRP. He also has special interest in aspects of trunk control and sensory deficits in cerebral palsy. We welcome you, sir, and also I welcome ExRxIndia's pillar, Ms. Duna, and all the participants from all over the globe. And I request our resource person to start the session. Please, sir.
Thank you, sir. Thank you for the kind introduction. And I take this opportunity to thank and also congratulate Chandramohan sir and the ExRx team for the work they have been doing. I've been seeing them for a while during the pandemic and thereafter in conducting these webinars, and it is a good way of propagating the profession, and they've been doing it in a good way. Congratulations, sir. Me start my... Are you able to see the screen, sir?
Yes, sir. Kindly
go for the full screen view, sir. Yes, sir. It is available now.
Now, is it in full screen?
Yes, sir. Full screen.
Okay. Okay. Good evening to all the participants and myself, Nelson Arputharaj John. And I take this opportunity to wish you all on a happy World Physiotherapy Day, which is tomorrow. And we are all involved in a very noble profession in the service of humanity. So it's not only a profession to thrive, it is also a profession to make people live. And it is more than a satisfaction to see the smile in a patient's faces. So I take pride in saying that I'm a physiotherapist. I hope the same with you all. Anyway, with wishing you all a World Physiotherapy Day, I move on to my presentation. And the World Physiotherapy has taken the theme for this year as osteoarthritis. Okay, osteoarthritis is a very common condition we see. Yeah. Okay. So osteoarthritis is a very common condition we see in our clinical practice. We see many patients, mainly aged patients, men and women, come with problems in the knee, and mainly the problem is that knee pain with the limitation of the range of movement and difficulties in their activities of daily living. So it's a very common condition we see. And of late, it is characterized as one of the chronic diseases, chronic musculoskeletal diseases. Considering the present healthcare facilities, we have more and more of aged population because the life expectancy has increased over the years, and because of which we see the prevalence and incidence of this OA is on the rise. It's on the rise, and this OA, we consider this the osteoarthritis. We consider this as a progressive condition. Progressive in the sense not with respect to only the features which we see in the joints, but also in how the patient lives. A patient who has a pain in the joint gradually starts experiencing more and more of pain, with which results in a functional decline. I'm talking about pain because pain is a very predominant factor. Of course, they have other features also, but this pain is a very major factor which gradually increases, which leads to functional decline. So a patient who had a problem with walking too much now even has problems in very trivial activities, getting up from a chair or climbing the stairs. So this affects his activities of daily living in a way, and which is going to affect his quality of life, because as humans, we are all created to move. So locomotion is a part and parcel of human existence. So when this gets affected by any problem, as like osteoarthritis, it very severely affects the quality of life. People become affected by loss of movement or a functional decline. It very much affects the quality of life, and it also affects the healthcare costs, okay, and also the burden on the society. So in this way, we can also consider it as a progressive condition. Right. So this osteoarthritis is mainly characterized by loss of cartilage. This is what we have been seeing. We mainly define this osteoarthritis as a loss of joint cartilage. You know that joint cartilage is a structure which is present in the synovial joints, mainly the weight-bearing joints. It has a greater implication where it helps to protect the joint, and we see in osteoarthritis there is a destruction of this tissue. So this leads to more and more of pain and loss of function. So the major joints which are affected are the hips and knees, and the upper extremity, mainly the hands. And we see men and women are both affected, with men have a higher predisposition to being affected. And we have been considering this as an elderly condition, where we see patients, more number of patients reporting greater than 60 years of age. But that is not the actual case, but we clinically see more of aged people being affected by this condition. So, and considering the healthcare which is increasing more and more, the facilities increasing more and more, rehabilitation which is becoming more efficient and sophisticated, we have more life expectancy nowadays. So we have more aged people living among us. So considering this, the WHO in 2003 itself, they have mentioned that osteoarthritis would be the 4th leading cause of disability by the year 2020, and that is true in a way, and that is what we see. Okay, moving on, these are some basics where we talk about certain risk factors which are predisposing to osteoarthritis, and the primary risk factor is a joint injury or an overuse, we say. Okay, we usually, when people come and report with the osteoarthritis, we usually say like, okay, it is a part of aging, but it is not actually so. It happens with aging, but it's not a part and parcel of aging. But the primary reason is some kind of joint injury or overuse must have happened. And age, okay, age, we previously consider it as a condition which affects the elderly, okay, but even the younger age groups are also liable to get affected. And with respect to more and more women are being affected as compared to men. We, as physios, we mainly attribute it to the differences in the biomechanical alignment, right? So biomechanically, we say that women have a broader pelvis, and because of that, the loading mechanism is a little different between men and women. That is why we see that women are being more affected than men. We see, but there is another cause, like morphologically also there is a difference between men and women. They found that the women have thinner cartilage as compared to men, so that can also be a reason where OA is mainly more predisposed to bearing excessive loading of the joint. Genetically, there is also a predisposition. It is not actually an hereditary disease. It's not actually an hereditary disease, but we see that there is more people affected in families, in families. This is attributed to genetic changes and changes in genes which are mainly responsible for formation of cartilage and bone. So that is one of the reason. And race. We see the condition is more prevalent in certain conditions, certain races, mainly African Americans. They say they have a higher incidence, but why it is so, it's still to be proven. Moving on, this one I've taken it from World Physiotherapy site. It was good actually, where they were explaining about the certain myths related to osteoarthritis. Okay, we usually consider osteoarthritis as a condition affecting the elderly, and we see it clinically also, but it is not so. It is not that only the elderly are going to be affected. Okay, we have even the younger age groups which are being affected. You see 50% of youth, okay, who are having a joint injury in 10 to 15 years are more liable to get osteoarthritis. Okay, so after a joint injury, the main aspect is the rehabilitation. How well the rehabilitation is being given, or how well the rehabilitation the patient is complying with, will determine whether they will be having OA in a later part of life. And another myth is like we usually correlate the findings with radiographic changes. Okay, but that is not actually so. We see a lot of people with extensive joint changes, but reporting less of a pain, and even people with the lesser joint changes reporting more amount of pain. So this shows that pain is not actually or directly related to a structural change in the joint. So pain is being influenced by many factors. Okay, like the patient's mood or emotions, or the level of activity, the sleeping pattern, the fatigue levels, and all those things are factors which can cause pain in an individual. Another factor is they say like no matter what I do, OA will get worse. Some people, they have an opinion that I've damaged my joints, my joint is degenerating, so exercise I may further injure it or further damage, but it is not actually so. Exercise is a way of keeping the joints healthy, provided the exercises are done in a proper manner. And to talk about that, physiotherapist is the best person who can decide on what exercise is best for that particular patient, for that particular condition. And we usually have an opinion that OA is a wear and tear. We call it as a chronic degenerative condition, like that's a age related. We say that there's a progressive degeneration happens. It's a wear and tear. It happens because of aging process. That's what we say, but it's not actually so. That's we can say there are many other factors which can lead to joint getting degenerated. One of them is a neuronal implication, the neurological factors which can lead to joint destruction. That's what we are going to discuss today. So these are some of the other basics, like clinical features. Like main feature which we can see is joint pain, which is mainly linked with function, linked with movement. Okay, so what is seen as a pain which is coming on with strenuous activity, gradually increases in intensity. Even a trivial movement can lead to a pain later. And some of the mechanisms can be neurological in nature, which we discussed. Then we have tenderness mainly in the medial joint line, and then we have crepitus. This crepitus is mainly because of the cartilage becoming hardening as the disease progresses. And then we have progressive stiffness and the limitation of movement. So considering a main factor, these are all the factors which we see in a patient affected by osteoarthritis. But considering pain is multifactorial, we know. So here, with respect to osteoarthritis, pain is it is an interplay between the structural chain, which actually happens, and also certain peripheral and central pain processing mechanism. So pain is not related to only the degeneration which is happening in the joint. So it is multifactorial. So there are certain things which happen peripherally. There are certain things which happen centrally in the nervous system, which can also lead to the joint destruction and degeneration. Moving on with all this, MAHSA in 2011, long back, he said like this loss of function and pain are weakly correlated with severity of disease or the radiographic findings. So we don't actually go by how far the radiological changes are seen or how far the disease is progressing. Okay, so pain, mainly pain and the subsequent loss of function is related to the severity of the problem. It's not only related to the severity of the problem. We have some neurological implications to it also. So this shows that there is a discordance between the degree of articular pathology and pain which is experienced by the patient. So this pain which is being experienced is subjected to individual variability, and this individual variability is existing based on changes in the central processing system, central processing with respect to the nociceptive stimuli which reaches the brain from the joint. So in this case, some patients may have hyperalgesia, some patients may have abnormal pain sensitivity, and some patients may have a referred pain. So, so this individual variability or differences exist. So this can be attributed to the brain processing mechanism, actually, not directly related to the degeneration which is happening. So some of the basics, we know that we have certain fibers, mainly the A delta fibers and A beta fibers. So these A delta fibers, they innervate the synovial capsule, the periarticular ligaments, menisci, periosteum, and the subchondral bone. And the beta fibers also, they innervate the synovial capsule, the periarticular bursae, the fat pads, the ligaments, menisci, and periosteum. The difference between them is then A delta and C fibers, they are mainly activated by noxious stimuli, which are noxious mechanical stimuli, that is pain or movement, thermal stimuli, chemical stimuli. So these kind of stimuli try to stimulate the A delta or C fibers, and the beta fibers are mainly activated by movement as such. Okay, so with respect to osteoarthritis, we know, okay, we have seen that it is a degeneration happening in the articular cartilage. Previously, we used to think like, okay, now the joint is degenerating, and there is articular cartilage which is covering the joint and which is being eroded day by day. At one point, when the articular cartilage has degenerated to a point where the subchondral bone is being exposed, that is where the patient starts to experience pain. So this is also a mechanism, but this is not the only one, because we know that we have studied that, we have known that the cartilage, the articular cartilage, is avascular and it is aneural also. So that is why a patient, as long as the cartilage is there, he doesn't experience pain usually. But this is not actually the so in every case. Like for example, in severe OA, osteoarthritis, the blood vessels, they breach the articular cartilage time mark. So what does it mean is like the articular cartilage, even though it is avascular and aneural, as the disease is progressing in severe OA, this becomes vascularized because there is vascularization. There is also neural innervation, neural breach into the articular cartilage. So this vascularization leads to sensory and sympathetic nerve innervation, okay, of the articular cartilage. So this contributes to pain in some patients. So this leads to a hypothesis of a neuropathic mechanism, okay, which can lead to pain. So even though if the cartilage is dead, so not necessary that the cartilage has to be fully eroded to expose a subchondral bone whereby the pain is being experienced by the patient. So even before that, when the condition is progressing, so there is a possibility that the patient may experience a pain because of the vascularization which is happening to the articular cartilage because the vascular diaphragm is broken. So this is some of the pathophysiology. Okay, so with respect to osteoarthritis, we know that the usual mechanism which we have read long before is there is a loss of articular cartilage, and which further on leads to a subchondral bone sclerosis. Okay, so this is one. And further on, articular cartilage gets degenerated by fragmentation, or there is a vertical cleft, or there is a crystal deposition happening, and remodeling also. Yes, here when the condition is progressing, the cartilage also tries to remodel, but they say that even the remodeling process leads to decreased densification of the bone, and which can also lead to a degeneration of the bone being aggravated. So what is happening to salvage is actually causing a destruction later, and which, as we have discussed before, there is a violation of the diaphragm by the blood vessel. So all these are some of the changes which happen with respect to the osteoarthritis. So with this, all this, we see, okay, what is happening inside the joint. So we know that a patient is affected by OA. We see that he is aged. Okay, we see he's an aged person. We see there's a gender, it could be a male or female. We see some visible symptoms. But there are certain things which happen inside the joint, which can also lead to the destruction which is happening in the OA. Okay, we'll see what happens. So this gives us a question. Is osteoarthritis a neurological disease? So considering this question, we have to think in three different angles. One is the osteoarthritis itself as a neurological condition, or there are some neurological changes which happen in an osteoarthritis, or it could be osteoarthritis causing a neurological disease, or in a neurological disease, osteoarthritis can be. So we have to think in these different angles. So if we think in these different angles, we come to a conclusion. We say that all these angles are possible. We have certain reasons to say that OA can predispose to a neurological condition. We have certain reasons to say that a neurological condition can predispose to an osteoarthritis. We also have some reasons to say that the osteoarthritis itself is considered as a neurological condition because there are so many neurological changes which is happening inside the joint. So as we know, anatomically, these joints, they are made up of complex nervous system. Okay, so this nervous system which controls the physiological functions of the joint. Okay, so they regulate the tissue blood flow. Okay, so they maintain the position sense, and also they modulate the pain mechanism. So these joints, these joint nerves, okay, so they not only provide a sense, a sense to the joint, it also regulates the blood supply. We know that in osteoarthritis, okay, so there is changes in the blood supply also. Okay, so this is also being mediated by the nervous system. Okay, so this nervous system not only is responsible for mediating nerve-related signals in the joint, it also helps, or it also mediates the vascularization or the aspects related to that. So these joint nerves or the nervous system in the joint, it helps to maintain the joint homeostasis. Okay, and thereby they try to maintain the tissue health. So when this neurovascular control is affected in a joint, so the integrity of the joint is disturbed, and thereby tissue destruction can lead to. This can lead to tissue destruction. Another thing which we have to consider is aging. Okay, so aging, we say that osteoarthritis is an age-related condition, but we attribute it to the wear and tear of the wear and tear process of it. As we age, there is a wear and tear, we say, and because of that, there is a destruction happening in the joint leading to an osteoarthritis. But that is one reason. The other thing which we have to take into consideration is what are the changes which happen in the peripheral nervous system then. Okay, so as people age, there is a progressive decrease in the joint proprioceptors and also a progressive decrease in the joint nociceptors. So this can be affecting their position sense, we call it as a proprioception. It can also affect their pain transmission. So these two are very important for maintaining the homeostasis of the joint position sense and also the brain transmission, because these two are the mechanisms by which a joint can maintain its integrity. So when these two are being affected because of the changes happening due to aging, there is an abnormal loading which happens. So this abnormal loading is going to lead on to further alteration in the joint mechanics, which can lead to a joint destruction. So this aging process is not only causing osteoarthritis because of the wear and tear, but there is a mechanism which is happening, which is related to the nervous changes which happens. So the main thing which interferes here is the position sense and also the pain transmission. So remember, these two are the important mechanisms by which the integrity of a joint is being maintained, mainly with respect to its movement and loading. Okay, so with this we can say that in addition to age, obesity, joint instability, and gender, we can say neuronal impairment can also be considered as a risk factor, okay, for the development and pathogenesis of pain. So this neuronal impairment, not necessarily that it has to be neurological disease or condition, but a neuronal change which is happening with respect to the physiology inside. Okay, that can also lead to a change in mechanism that leading to a progressive tissue destruction happening inside the joint with respect to the nervous system. Okay, I hope you can hear me. Okay, right. So the basic mechanism is like the joint tissues.
Sorry to disturb you. Last slide, it was like we couldn't hear you properly. There was breaking of your voice.
Is it this one, sir?
Yes.
Okay, okay. So with what we have discussed, I wanted to say that we are considering certain risk factors like age, obesity, joint instability, and gender. In addition to that, we also have to consider neuronal impairment as a risk factor in the development of OA, because this lead to destruction in the joint. Okay, so this can also be considered as one of the risk factors. So we'll see what is happening inside the joint. So the normal mechanism is the joint tissues, when they are being given abnormal loads, when they are subjected to abnormal high loads, there is a resulting injury. Okay, so this can lead to future OA. So the joint afferents, okay, when there's an abnormal loading, this joint afferent, they sense it, and they actually alert the system of this abnormal loading. So this can automatically lead to alteration of gait, which is actually to minimize the catastrophic loading. So we see a lot of patients, their gait becomes changed, particularly when there is a unilateral OA, there's a limping gait seen. Okay, this is a normal mechanism. So this is also being mediated by the nervous system. Okay, we say that patient is having a pain, and because of the pain is trying to shift weight and walk in a different way. This is one way. Another thing is the nervous system also mediates that. So when there is an abnormal loading, there is a the reflexes, the protective reflexes, they are getting triggered. There is an alteration in the muscle activity, that could be a change in the weight bearing, that could lead to an alteration in the gait. And this is happening because to salvage the existing tissues or to minimize the catastrophic loading. That's what we say. But in certain cases, this can also be detrimental. See. Okay, so so based on this discussion, we can conclude that damage or dysfunction of the joint nerves, it can affect the normal health of the joint. Okay, so further on, we'll see what is happening. Okay, so considering the joint. Okay, so the joint, okay, is being maintained, okay, by a vascular system and also by a nervous system. In the joint, mainly the synovial joints, which are being affected in OA, the main nerve center is the synovium. Okay, because more and more nociceptors are being present, or the maximum density of the nociceptors are the synovium. Number two, the joints are also innervated by postganglionic sympathetic efferents. And these sympathetic efferents are in close proximity to the arterioles. mainly the blood vessels. So as I said, the homeostasis of a joint, it depends on the homeostasis of the nervous system and also of the vascular system. So both has to be under control. So we'll see what is happening. So studies have shown that we have seen that there is a nerve center which is a synovium, which is full of nociceptors, and then we have the postganglionic sympathetic afferents, which is mainly present near the vascular structures, arterioles. So this is going to affect the vascularization process, and the other center, the nervous, the synovium is going to be affected because of the change in the nervous system. Right. Okay. So the electrical stimulation being found that there is when the electrical stimulation of the sympathetic fibers, it leads to a reduction in the synovial blood flow. Synovial blood flow. Another thing is a guanethidine induced sympathectomy. They say, to make it more simple, it is antihypertensives. Okay, so the antihypertensives, when they are being taken for a longer time, it causes a chemical sympathectomy, which can also increase the synovial perfusion. So if you can see the changes in the sympathetic fibers. Okay, so when there's a change in sympathetic fibers, when there is a decrease in their activity, it is going to increase in the synovial perfusion. So in OA, this mechanism can also be disturbed. Okay, so this mechanism, when it's being disturbed, okay, mainly the nervous regulation of this system, when it is being disturbed, that would alter the blood flow to the tissues of the joint. Okay, this can lead to further tissue breakdown and disease. Okay, so the normal mechanism, okay, so there is a tissue loading, and because of that, there is a destruction. We say that's a normal mechanism. Another is the mediation by the nervous system, and also mediation by the vascular system, that can also be leading to tissue damage. And there is another finding, okay, which has been published in 2012, which says that OA can also be considered as a bilateral disease. We have seen and we have read before that rheumatic diseases are mainly considered symmetrical and bilateral. But they also propose that OA can also be bilateral. And this mirror imaging is mainly mediated by the peripheral nervous system. Peripheral nervous system is the one which mediates this mechanism to make OA as a bilateral condition. This can be seen in patients with stroke mainly. So the normal mechanism is when there is a joint proprioception, there is a when there is a loading happening in the joint, and there is a problem. When there's the proprioceptive loading is not proper, it can lead to an altered gait, which is leading to an abnormal loading and causing a tissue destruction. You see in a patient with stroke, they see mostly patients with the stroke, they get osteoarthritis in the contralateral knee. Okay, if they are getting osteoarthritis, mainly if you can see in a patient with stroke, if there's a right hemiplegia, there is more likelihood that they get osteoarthritis on the unaffected side, the opposite side. We usually attribute it to altered loading. We say that because of decreased weight bearing on this side, there is more amount of weight bearing on the other side, which can lead to abnormal loading. Okay, abnormal loading, which can lead to tissue destruction. This could be one of the reasons. Another reason can also be neurologically mediated. So in this condition, what happens is there is an antidromic conduction of nerve fibers. Okay, so this antidromic conduction of nerve fibers, the sensory fibers mainly. So antidromic conduction of nerve fibers, sensory fibers means the impulses in the sensory fibers, the impulses are coming from the spinal cord towards the periphery. So what happens is this mediates to the peripheral release of certain inflammatory neuropeptides. So these inflammatory neuropeptides are these inflammatory chemicals when they are being continuously loaded. So you see the patient is having a OA, and because of that, and it is progressing in nature, because of that, what happens? There is a change which happens in the peripheral system. This change or this sensitization which happens in the peripheral system, we'll see about that later. There is a change happening in the peripheral system which is leading to its increased sensitization, which can lead to an antidromic conduction. okay, which happens in the opposite direction in the sensory fiber. This leads to more and more inflammatory mechanisms in the joint. And this antidromic conduction can also lead to hyperemia, leukocytic chemotaxis, which can injure the joint, and also this edema formation. Okay, so this OA, as it progresses in nature or if the severity is increasing, this is furthermore going to sensitize the nervous system. The nervous system is going to be sensitized to both peripherally and also centrally. When they are being sensitized peripherally, what happens? There is a mechanism by which an antidromic direction of conduction happens in the sensory nerve, which can lead to release of inflammatory chemicals into the joint. Okay, so this can lead to hyperemia, which can lead to chemotaxis, which is injuring the joint tissue, and also lead to an edema formation. So this is more attributed to something which is happening in the thing. Another mechanism which can happen is when the myelinated afferents are being affected. Because these myelinated afferents, which are present in the joint, they are highly sensitized to mechanical stimuli. Okay, so as the joint is being overused, these myelinated afferents, they are the one which is sensed, and they are located throughout the joint, and they help in maintaining the position sense. So this large diameter fibers, when they are getting affected, okay, so when this loss is happening, it can further lead to loss of these protective responses. These proprioceptive reflexes can be affected, leading to abnormal loading, and this can be affecting the joint. And where we see this happening is, you can see this happening with respect to age. As we age, okay, there is more and more loss of large diameter fibers. And when there is a loss of large diameter fibers, what happens? There is a decrease in the position sense. This position sense can lead to loss of proprioceptive reflexes, leading to abnormal loading, which can accelerate the joint deterioration. So what we see in aging, okay, so it's not just a wear and tear. It is actually a mechanism happening in the nervous system, which is leading to tissue destruction, which can lead to OA. Okay, so this has been proven in animal studies also. The nociceptor density, it is reduced in the OA patients. So all these observations show us there is a high degree of neurosensory attrition in OA joint, which leading to altered pain perception and also the neurovascular control. So as I told you, these are two mechanisms, okay, the neural mechanisms and the vascular mechanisms are responsible for maintaining the homeostasis. And here we have this both these mechanisms being affected here. So as the condition progresses, a patient with the pain in OA is not only related to the tissue destruction as such, but also related to the nervous system change, which happens in response to the tissue destruction. So moving on further, we also have to discuss on how the nervous system centrally and peripherally. As I told you, the joints homeostasis is being maintained by two main mechanisms, the neural and the vascular system. And this neural mechanism, okay, it's the one which is because this neural mechanism, sorry, this as a disease is progressing and progressing, its sensitivity starts to increase and increase. We call it as a peripheral sensitization. So there are certain mechanisms which happen related to that. So in response to this, there is also a central sensitization which happens. So what has started as a pain which is more peripheral now gradually becomes more and more as a central pain. So we start treating patients as pain happening in OA because of a peripheral mechanism, but we cannot be relying on that mechanism only, because as the condition progresses, because of the increased peripheral sensitization, more and more pain is becoming central. So what is happening here? So continuous shear and compressive forces. okay, which is happening during locomotion, is being sensed by the joint, the primary afferents, and is being taken to the nervous system. So this receptors are mainly present in the joint capsule, the ligaments, menisci, and the subchondral bone. So in OA, what happened as the condition is progressing, there is a pain which is progressing. So because of that, there is a mechanogated ion channels which are open. So these are sensory receptors. So when these sensory receptors are getting open, more and more action potentials are generated. Actually, this is a normal process. This is a normal process by which when the sensory receptors are stimulated, the mechanogated channel potentials being generated. In a normal sense, the electrical activity or this generation of action potential is being sensed by the central nervous system as a normal movement. Usually it is sensed as a normal movement. But what happens as the condition progresses, more and more stimulation starts to increase more and more opening of mechanogated channels. So this starts to stimulate the sensory nerves more and more, which leads to further bombardment of action potentials. So this bombardment of action potentials, when it reaches the brain, so a normal sensation, the brain starts to perceive as pain. So this is so what a patient started with as a pain which happens with the prolonged activity, now starts to get pain with trivial activities also, and it particularly degenerated and inflamed joints. This activation threshold, okay, it starts to gradually reduce and reduce. So the neurons now start to fire even for a normal innocuous movements. So previously, very exerted activity only causes pain. As a condition progresses, even minor activities causes pain. So why it is happening? It's not because of progressive degeneration of cartilage, but progressive sensitization of the nervous system. So the peripheral nervous system first initially acts and it becomes sensitized, and this sensitization is being transferred to the central nervous system also. So previously, a normal action potential was action potential which was generated was considered as a normal movement, but because of this hypersensitivity, more and more mechanogated channels are opening, which actually keeps the sensory nerve more and more sensitized. So this continuous bombardment in a chronic condition leads to the brain perceiving even a normal movement as very painful. Another mechanism which happens is as the condition progresses, there is a nociceptor sodium channel. So these channels are also likely to open in arthritic joints. So what this contributes to, this contributes to nociceptors being highly sensitized, and gradually what happens, the pain which was present on activity now even presents as pain on rest also. And how this is happening? This is happening because of a process which is initiated by release of inflammatory chemicals. And how these inflammatory chemicals are released into the joint, as we discussed before, it's because of the antidromic conduction which happens in the sensory nerves, which leads to sensitization and which leads to release of inflammatory chemicals. And not only this, sometimes even in case of damage to the peripheral nerves can also lead to this phenomenon. So we have some, like for example, any peripheral nervous system conditions can also lead to this kind of mechanism, leading to a tissue destruction, thereby a hole. Another factor which has been implicated is a nerve growth factor. So this nerve growth factor is actually a neurotrophic factor, but they have found that this nerve growth factor is also having a potential in OA pain. Particularly, this nerve growth factor can sensitize nociceptors and in the long run can cause continuous pain. Another mechanism which we already know is the endogenous opioids, okay, or the endomorphins. The endomorphins are the natural pain-producing, pain-relieving substances. And what happens in the normal mechanism? Actually, they are located in the joint nerves, and upon release, they actually help to reduce inflammation and also nociceptor firing. But in chronic arthritis, because of peripheral sensitization, what happens is receptors for this endomorphin are downregulated. So now we have no longer have this endomorphin to decrease inflammation or to decrease the nociception. This is also another mechanism which can happen as the condition is progressing, which is being mediated by the nervous system. So what are the neurological implications? How we relate this osteoarthritis to a neurological condition? For example, we have this Charcot arthropathy. This Charcot arthropathy, we consider it as a painless degeneration of the joint. There is a loss of sensory innervation to the joint, and there is a painless degeneration. They see that there is a similarity between this and this condition and an osteoarthritis, because in osteoarthritis, it shares the clinical features with a Charcot arthropathy, because we see in OA also there is a incidence of peripheral neuropathy, the peripheral changes which we have seen, osteophyte formations are there, and different levels of synovitis are seen. And in both these conditions, there is a destruction which is due to loss of proprioception, which further leads to generation of dysesthesia and abnormal joint loading which happens. So this is again, we can consider this as something happening more peripherally. But there are certain things which even happen centrally. So they have found that in imaging, there are some morphological changes which are happening because of, particularly there is a decrease in the thalamic volume. They say that in chronic OA, as the condition is progressing, the thalamic volume is decreasing. We know the thalamus is the main area which is transmitting the sensory impulses with respect to discriminative and affective nature of pain to the cerebral cortex. And in OA, this thalamic volume is getting decreased. So that can also be a reason of dysesthesia which is happening later. So this is actually a morphological change which is happening in the brain. Not only the thalamus, even they found that some deep brain structures which are associated with the affective aspect of pain, they are also found to be becoming smaller in case of OA. So the OA is not something which is happening in a peripheral joint. It is something which is causing a change in the overall nervous system. We see there is some changes happening in the peripheral area of the nervous system. We also see some changes happening in the central area of the nervous system. And the changes which happen in the central area of the nervous system is more morphological in nature also. There is a structural change also which is happening. And the interesting part is this brain atrophy, which was seen in chronic OA patients, after a total joint replacement, there was a reverse here. Okay, so this brain atrophy, which was seen, was actually reversed in patients who had a joint replacement. So what does it lead us to? It leads us to a point to consider that there are certain changes which is happening in the peripheral nervous system in response to osteoarthritis, which is actually the reason why this brain morphology is changing. So other reasons, other aspects to be considered in OA is the motor deficit. Okay, so the motor deficit, one is we actually attribute it to the pain. Because of the pain, the patient is not able to walk, the patient is not able to climb the stairs, his aerials are affected, that is an aspect. But the motor deficit in OA is also related to changes which is happening in the nervous system as such. So there is an altered central processing, okay, because we already have discussed that there is a morphological change happening in the brain. And because of that, which is because of a peripheral sensitization which is happening, which also leads to an altered pain perception, altered central processing. So this can lead to motor reflexes being affected. You know that, show the next slide. Yes, they have found that there is a inhibitory, as the disease is progressing in OA, the persistent pain which the patient feels, okay, it's leading to activating inhibitory connections between the somatosensory cortex and the motor cortex. So when this connection is being decreased, or this connection, the strength of this connection is being decreased, obviously there would be a motor deficit which is seen. So this motor deficit which is seen in the patient, we actually attribute it to the pain and the changes which is related to that. Patient is getting pain, so it's getting a discomfort, so it doesn't move. But actually, along with that, there is a change happening in the nervous system itself. So patients with OA knee or OA hip, mainly the lower extremity, they may have motor deficits, which is because of not only something peripheral, but because of something which is happening in the central nervous system. So there is the persistent pain. It actually decreases the connection and with the strength of the connection with respect to somatosensory in the presence of OE, in the presence of persistent pain. Okay, so till now we have been discussing on the changes which is happening in the nervous system. Okay, so we know that osteoarthritis, even though we consider it as a musculoskeletal disorder, as a neuronal implication to it, there are many neurological factors which are related to it, neurological implications related to it, or the changes related to it, mainly with respect to the peripheral nerve system and also the central nervous system. So as I told in the beginning, when we consider it as a neurological disease, we have different angles to look at. One is we consider that happening. We can also consider that as a condition which can lead to a neurological disease. We can also consider that as a condition which is a result of a neurological disease. So there was a study which was done in Taiwan. Here they have compared two groups of individuals, one with OA and one with a non-OA group. So what they found is interestingly, this it's a cohort study. So in this cohort study, what they found is the people or the subjects with OA were mainly predisposed to getting stroke later. This was curious. Okay, what does OA got to do with getting a stroke? But actually, they found a 35% increase in the patient with OA getting a stroke. So what can be the reason? What we can see here is, okay, this OA is a condition which can be debilitating as it progresses, which can lead to a decreased physical activity. So this decreased physical activity, it represses the endothelial function. It increases the blood viscosity. Okay, thereby it can increase the risk of stroke. It can be one of the factor which can be a risk factor for a stroke. So we can attribute it to the loss of physical activity. So this is one reason which we can see. Another reason which we can implicate here is when there is an OA progression, what happens is there's a weathering of the affected joints. And there is a low-grade inflammation. As a condition progresses, there's a low-grade inflammation which is seen. There is a high degree of correlation between inflammation and atherosclerosis. So these patients with the continuous or the chronic OA patients, because of the low-grade inflammation, they are more liable to get atherosclerosis, both in the intracerebral arteries and also in the extracerebral arteries. This can lead to the pathogenesis of stroke. So this is another implication. So here we think that OA is a musculoskeletal condition which is related to the joint and its function, but it has implications more neurologically. So in the previous discussion, we saw that there are some nervous changes which are happening in OA, but now we see that OA can even predispose to a neurological condition. So there is a possible factor. The third is we see OA knee as a condition which is happening because of a neurological condition. So is that possible? That is also possible, because in certain studies they found that degenerative arthritis is common in neurological conditions where there is asymmetrical muscular weakness and secondary gain of impairment. So mainly they found this incidence of OA knee in those neurological patients affected by movement disorders mainly. Movement disorders means the movement disorders which are more in amplitude. If we consider like for example a coriform movement, this can be a high in amplitude. So they found that incidence of osteoarthritis is more in those kind of neurological diseases or conditions where the movement disorder is existing, and that movement disorder should be of a high amplitude. So that is why comparingly they see that in Parkinson patients the incidence is low comparing to the high amplitude movement, because in Parkinson the amplitude of movement is low. They may develop later because of the decreased physical activity, but because of the neurological implication, it is comparingly less because the amplitude of movement is comparingly less, even though it is considered as a movement disorder. So in those conditions where the movements are coriform, those conditions where the movements are ballistic, those conditions where the movements are dystonic, there is more chances that it can lead to or it can predispose to osteoarthritis later. Right. So with all these, okay, I want to finally conclude that when considering the risk factors of stroke, we have been discussing at that gender, obesity, or abnormal biomechanics as a risk factor for stroke. But we should also consider that there is a significant proportion of neuronal elements which affect the joint leading to an osteoarthritis. So this neuronal impairment can also be considered as a risk factor in the development of joint. So this is a knowledge sharing to just to explore the neuronal aspects of osteoarthritis. I'm not discussing the therapeutic aspect of it. So this one, this is actually to see the other side of OA. We have been seeing OA as an a musculoskeletal condition which is mainly affecting the joints, but we should also consider a neuronal aspect to it. So an understanding in this way can lead to alterations in a therapy further in the further days to make sure that a balance exists both in the musculoskeletal system and the neurological system, both in the prevention and the management of osteoarthritis. This I conclude my presentation. Thank you for listening.
Yes, sir. Thank you, sir. Thank you so much, dear participants. And we are posting the Zoom link in the WhatsApp group now, and also we'll try to post in YouTube also. Those who are having doubts can join the link and ask our resource person your queries. And meanwhile, it was a really very good presentation, sir. We can go screen off now. And if needed, we can share. Just a second, sir. I will be posting for participants. The participants are posting the Zoom link. Kindly join through Zoom. Those who are having doubts can talk to our resource person, Mr. Nelson. Many of us think that osteoarthritis is only musculoskeletal, and or maybe those who little know more, they will think about only it is neurological and musculoskeletal, but indirectly it affects the cardiostatus also due to the physical activity which gets lessened. So the person who get affected by osteoarthritis goes for premature death also. So it affects the cardiostatus also. Am I audible, sir?
Yes, sir. I'm listening.
Okay. So I will repeat that. Many of our physiotherapists think that osteoarthritis is musculoskeletal, and a little more they know that they will think that it's a neurological. But it also affects the cardiostatus, that is heart also. When the lifestyle gets changed from active to little lower, or a sedentary lifestyle due to the pain or the deformity due to the arthritis. It affects the cardiostatus, and they will end up in some other heart problems, or they may end up with a premature death also. There are studies done in that also. I think we have participants, Dr. Chitra Patnis, Jay Lakshmi Nagarajan, Kritika Manoharan, and Annie. If you have any doubts, you can ask our resource person. Meantime, I will be posting in other groups of our ExRxIndia group also. Any doubts, dear participants? Let me check YouTube also now. So those who are having, yes, there is one question asked by someone. I will checking. So from Payal Shah, she asked, how can we say that there is a central pain mechanism?
Yes. Okay. So the central pain mechanism, sir, am I audible?
Yes, sir.
So the central pain mechanism doesn't start from itself. The central pain mechanism or the central sensitization is actually the result of the peripheral sensitization. So in the peripheral sensitization, what happens? In a normal sense, when the sensory nerve endings are being stimulated, the action potential starts to get generated, which is the electrical impulse of it is sensed by the central nervous system as something which is normal. But as this progresses, what happens? Gradually, the sensitivity of these nerve endings increases. As I told you, another reason can be because of an antidromic conduction, can be because of the increased opening of the mechanogated channels and sodium channels. So this can lead to further more and more increase in the sensitization of the peripheral nerve endings, which increases the action potentials. This bombardment of action potentials, as it reaches the brain, now the brain starts to sensitize pain. So now the normal movement, as this condition keeps on increasing, this leads to further central sensitization, which can lead the brain to sense even a normal movement as pain. So this is how the peripheral central sensitivity. This doesn't actually happen by itself, but it is a result of a gradual increase in the peripheral sensitization, which leads to this central sensitization. So that is why, like in the initial stage, when the patient is getting pain, they complain of pain with more strenuous activities, walking too long or climbing stairs up and down for long. But as the condition progresses, even a trivial movement can become pain, like they sit and when getting up they may get pain. So trivial movements can even produce pain. So one of the things which we attribute it is to the wear and tear, and we see that the condition is improving. I mean, the condition is recurring further. More and more loss of cartilage is happening. We attribute it. That is also happening. The other thing which can happen is, as the condition progresses, is the central sensitization. So that is why even a trivial movement can be perceived as pain. That can also be a reason why the pain intensity is gradually increasing in the patient.
Yes, sir. And yes, sir. We have the next question now. And sir, as you said, a normal movement in OA stimulate the nociceptor because of its reduced potential. Just a second, sir. That is reduced potential action. That means avoiding movement in early management is good. Am I audible, sir?
Yes, sir. Yes, sir.
So I have not posted it in chat box, just reading it out because it's a query from YouTube actually.
I have posted in chat box.
Yeah, sure. It's from Rimmy Khan, right? Okay.
Yes.
Yeah, right. So this process, it takes time. So this process, it takes time. So it's not mandatory to stop movement at the early phase. So we see that this process is taking time, where there's more and more sensitization happening, so that increased pain perception is happening. So here, instead of decreasing the movement, we have to think of some therapies which is acting more centrally. So we are going to target not the joint here, we are going to target the pain perception here. So that is how we have to shift the thinking. So here the increased pain or the discomfort is not something which is happening peripherally. If it is happening peripherally, then we can start to decrease the movement. But it's something which is happening centrally. So what we have to do is think of certain therapies which act centrally, pain modulation centrally, which can affect, which can help in decreasing the pain perception. Can be more subjective also.
Yes, sir. And the next question is from Chandra Bhatran. Is there brain atrophy in patients with chronic OA in adults?
Yeah, that's what they have found. They found that imaging studies have found that there is a decreased volume of thalamus noted in chronic OA patients. And we know that thalamus is a structure which is responsible for sensing the discriminative and affective nature of the pain. So when that is getting affected, that can lead to dysesthesia later. So there can also be a reason why patient may get an hyperalgesia, allodynia, which can be happening. So that is also happening.
And the next question is from Smith Wickles. Can we apply neuro approaches and techniques in treating osteoarthritis?
Okay. More questions towards management. Right. So neuro approaches. Okay, of course we can. Because here we are talking about osteoarthritis as something which is peripheral, more musculoskeletal, but leading on to further centralization of the pain. So when we talk about approaches, more kind of functional approaches which can help in re-educating imagery, motor imagery can help. Okay, so because here we have certain morphological changes we say we have, and we also say that in chronic OA there is a more amount of inhibition between the sensory cortex and the motor cortex. So in this case, definitely neuro approaches can help. Okay, any function-based approaches which can further emphasize on motor learning, motor imagery can help.
Yes, sir. The next question is from Krishna Kumar. Lack of nutritional factors in the synovial fluid and increased inflammatory factor in blood can cause OA.
Lack of nutritional factors in the synovial fluid and increased inflammatory factor we have discussed mainly with respect to the nervous system. We talked about peripheral sensitization. We talked about antidromic conduction. This antidromic conduction is going to cause peripheral sensitization, increasing the release of inflammatory chemicals. So when there's a release of inflammatory chemicals, there is more possibility of the destruction to happen, edema to increase, okay, and also the synovitis to increase. So those things can happen.
And the next question is from Mohammed Arshad. So afferents send dysfunction as correct to brain. Then how can we correct that?
Yeah, that's what we said. Like that's where we have to shift our thinking from managing OA peripherally into managing OA as more holistically. Okay, so we need to be thinking of therapies which manage patients centrally. So central pain modulation we have to think of. We have to think of a central pain modulation. So that those therapies which act on central pain modulation, we can consider that can be helpful, mainly in the chronic stage of the condition. Because as the condition progresses, the pain is a multifactorial nature. It is subjective also. So when we talk about pain, as we also said that the radiographic finding is not directly related to the pain which the patient feels. So here in this case, as the condition progresses, we have to shift our focus from more peripheral kind of management into a central kind of management. We can think of pain modulation, which can happen more in the central pain modulation. We can think of.
Yes, sir. The next question is from Praveen Kumar. What will be the role of TDCS in OA?
Are they talking about transcranial stimulation?
Maybe I request Praveen Kumar, have you joined in our Zoom meet? If not, can you kindly join? I have posted the link in YouTube chat also. So we will move, meantime we will move on to the next question. Sir, will virtual reality help in decreasing pain?
Of course can. See, pain is, as the condition progresses, pain modulation changes, pain becomes more subjective nature. So virtual reality can help. Virtual reality can be used for many things to re-educate movement, to decrease the pain perception also. Virtual reality can help. See, virtual reality is like we are putting the patient in a virtual environment. So with that, we can think of modulating movement, modulating pain, anything we can think of. It depends on what kind of virtual reality we are using. Still, it can be thought of as a viable option.
Yes, sir. Praveen Kumar, are you there? Can you respond? Either you on YouTube, you can write there.
It is transcranial direct current stimulation, sir.
Actually, I don't have much strong evidence to say it can help. What they actually feel is like when they give this, actually this can help in what to say, training motor control actually, but with respect to pain modulation, I'm not really sure. I don't think that can help in pain modulation. Yeah.
Yes, okay, sir. And any questions from other participants, those who are joined in our Zoom chat? Yes, I think no more queries, sir. In case if you have any queries, we request. And
Sir,
there
a
is
question
one.
is there. I have posted in chat box. Kindly check.
Yes, there is a question. Will neural approaches helps in acute joint pain?
Yeah, acute joint pain, not necessarily in an acute joint pain. As the condition progresses, it may help because initially we see that they take some time for peripheral sensitization to happen actually, and which further on leads to central sensitization. So as we discussed, it takes some time. So that is why we see more of these changes in chronic way. So in chronic OA, when pain modulation changes, when pain becomes more of subjective nature, then we can think of neural approaches. Yeah. Neural approaches, I'm not very sure about what neural approach is talking about, but I'm talking about neural approaches, neuro restorative kind of approaches that can also help in modulation, but at a later stage. At a later stage, it can.
Okay, sir. And Praveen Kumar, we have answered your question. Yes, we have got that transcranial direct current stimulation. And Muhammad Arshad is saying once we fix the centralized pain and is peripheral pain fix itself, or we need to correct that?
Actually, the peripheral pain sensitization is actually the reason why this central sensitization is happening. So that is why you see like the brain morphology which has changed, it reverses when the total knee replacement is being done. So that shows that this is the reason why that is happening. Okay, so in this case, can we fix central and this? Okay, if we fix the peripheral pain, there is chances of central pain. But as far as I know, when it has become more central in nature, it becomes more subjective. Pain doesn't become a morphological experience; it becomes a subjective experience. So initially, for the process to happen, there is a link between a peripheral sensitization and a central sensitization. But as it becomes more, because initially the link is more morphological in nature. But as it progresses, it becomes more subjective in nature. So we need to think of managing here, okay? And of course, managing here mainly. So that's why we, as the disease progresses, we think of both central pain modulation mechanisms instead of peripheral.
Yes, Dina ma'am, is there any further questions?
No more questions yet, sir.
Yes, and we got a reply from Praveen Kumar also. He's saying thank you. And no questions on the Zoom chat also. And I think we can wind up for today's session. And thank you so much, sir. And it was really wonderful session. And we have started organizing the webinars after a long time, and you gave a good start. And we would like to invite you for tomorrow's session also to join with us, because it's really a very good topic, and every physiotherapist must know about the exercise physiology and exercise testing and prescription for osteoarthritis. So I invite you to join with us for tomorrow, and I invite all the participants, those who are registered, almost 700 plus participants registered for this. Kindly join with us. And the thing is, we have a very less participants in Zoom. That's why we go live. So those who have doubts, at the end of lecture for discussion, we will provide the Zoom link. You can join the Zoom link and you can interact with our resource person. Thank you, one and all. Thank you, Duna madam. Thank you, Nelson John sir.
Thank you, sir. Thank you very much.
Thank you so much, sir.
Thank you, ExRx team, and also thank you, participants, for the patient listening.
Yes, sir. Good night, sir. Good night, ma'am.
Yes, sir. Night, sir. Good night, Chandramohan, sir. Good night, Nelson, sir.